Okay, let's unpack this. Today, we're taking a deep dive into a topic that quite literally deals with life and death in real time. Advanced cardiac life support, or ACLS. Millions experience cardiac arrest every year, and in those frantic moments, the decisions made are absolutely critical. It's a field built on cutting-edge science, constantly evolving, and packed with surprising insights.
What's truly fascinating here and what we'll be exploring is how these global guidelines from groups like the American Heart Association and the International Liaison Committee on Resuscitation aren't static. They transform our very understanding of emergency care, often challenging, long-held beliefs. We'll uncover the why behind these shifts and what medical teams now know truly makes the difference when every second can determine someone's future.
Our mission for you today is to cut through the complexity and extract the most vital principles of modern ACLS. We want to give you a clear, informed perspective on how medical teams strive to save lives during cardiac emergencies. You'll gain, I think, a deeper appreciation for the precision, the constant adaptation, and the incredible teamwork involved in these high-stakes situations. So as you just mentioned, these ACLS guidelines are not set in stone. They're living documents, constantly updated based on new, rigorous evidence. We saw really significant updates in 2020 and 2021, which highlights this ongoing process. It's not just about learning a fixed protocol. It's about understanding why the protocols change.
Exactly, and that why is crucial. Resuscitation research is incredibly challenging, especially, in real-world human scenarios. So many recommendations aren't just from neat randomized controlled trials, but often rely on a careful blend of observational studies, animal models, and the consensus of top experts. All of these recommendations are then rigorously classified using a system called GRADE, which helps us understand the strength and certainty of the evidence behind each guideline. It's about building the best possible knowledge in a very difficult environment.
Okay, this is where my prior understanding gets completely upended. Like many listeners, I grew up learning ABC, airway, breathing, circulation. It felt intuitive. But you're saying modern ACLS has completely flipped that script. So for someone experiencing cardiac arrest, what's the radical new priority and why did the science demand such a dramatic change?
It's perhaps the most fundamental and maybe surprising shift. We now prioritize CAB, circulation, airway, breathing. This emphasizes that excellent cardiopulmonary resuscitation, or CPR, and early defibrillation are the absolute, non-negotiable cornerstones. Think of it this way. In those initial moments of cardiac arrest, the biggest problem isn't usually a lack of oxygen in the blood. It's that the oxygenated blood isn't moving. Without excellent CPR, you simply don't get enough blood flow to the brain and heart, which critically compromises a patient's chances for meaningful survival.
That's a powerful and simple phrase, excellent CPR. But in those frantic, high-stakes moments, what does excellent actually entail? Are we talking about just pushing hard, or is there a precise, almost choreographed science to it that goes beyond what most people imagine?
Oh, it's absolutely a precise science. The very first principle, and often the most challenging, is uninterrupted compressions. We now know that minimizing pauses is incredibly vital. In the past, clinicians would frequently interrupt CPR for things like checking a pulse or trying to intubate the patient or even just getting IV access. But current guidelines now strongly recommend against any unnecessary pauses.
Yeah.
Any interventions that haven't been shown to improve outcomes must be carried out while CPR is happening.
That is a huge change. Wow. I can only imagine how difficult it was for experienced clinicians to unlearn years of training to minimize those pauses. So the chest compressions themselves, how deep and how fast should they be?
Right. The target depth is between 5 to 6 centimeters, which is about 2 to 2.5 inches. And the rate is equally important, consistently between 100 and 120 compressions per minute. Another critical, often overlooked factor is complete chest recoil between compressions. You need to allow the chest to fully spring back, to let the heart completely refill with blood before the next compression. Think of it like a pump. If you don't let it reset, it won't deliver full volume.
Right, that makes sense. And is there a specific target for how much time should actually be spent compressing the chest versus pausing?
Exactly. We aim for a chest compression fraction above 80%. Imagine a basketball game. You want the ball in play, constantly moving, for at least 80% of the game. It's the same here. Compressions need to be happening almost non-stop to keep that vital blood flow going. Even brief pauses, as we mentioned, significantly compromise blood flow to the brain and heart.
So if compressions are now the absolute priority, what does that mean for airway management and ventilation? It sounds like the approach to breathing has also evolved significantly.
It certainly has, and here's another counterintuitive insight. When it comes to airway management, the science shows that in the initial minutes of sudden cardiac arrest, the problem isn't usually that the blood lacks oxygen, it's that the blood isn't moving to deliver the oxygen it already has. This is precisely why excellent chest compressions take priority over ventilation. It turns out giving too much air can actually be detrimental.
More isn't always better, you said earlier. That's fascinating. So what are the preferred ways to manage the airway now, then, if not immediate intubation?
Yeah, for initial airway management, simpler tools are often best. Things like bag valve mask or BVM devices or even supraglottic airways. These are tubes designed to sit just above the voice box to quickly secure an effective breathing path. They're rapidly placed, require less specialized training, and are generally very effective. Endotracheal intubation, which is placing a tube directly into the windpipe, can often be deferred until after the patient has a return of spontaneous circulation, or ROSC. If intubation is performed during CPR, it must be done incredibly quickly, ideally in under 10 seconds, and should ideally use video laryngoscopy, a camera-assisted technique, for better outcomes and to minimize interruptions.
And the danger of overventilation, how does that play out? How can giving too much air actually be harmful during such a critical moment?
Well, think of it this way. When you give too much air, or too frequently, it actually creates pressure inside the chest. This pressure then squeezes on the large blood vessels, returning blood to the heart, making it harder for the heart to fill up with blood. If the heart can't fill properly, it can't pump effectively, meaning less blood gets to the brain and other vital organs. It also increases the risk of inflating the stomach, which can lead to aspiration. So, yeah, in our attempt to help, we can inadvertently hinder.
Understanding the delicate balance of ventilation makes perfect sense. But in the chaos of a cardiac arrest, how do medical teams actually monitor all this in real time? Is there a critical piece of tech that confirms we're doing it right, from tube placement to the actual quality of CPR?
Absolutely. Continuous waveform capnography is a vital tool, a true game changer. It measures the carbon dioxide at the end of each exhaled breath. It's used to confirm that a breathing tube is correctly placed in the windpipe, not the esophagus. That's number one. Beyond that, it helps assess the quality of CPR. If the end tidal carbon dioxide, or ATCO2, reading is consistently low, say below 10 millimillibar Hg, it's a red flag. It suggests inadequate cardiac output and prompts the team to immediately improve CPR quality, push harder, faster, allow recoil. And a sudden, sustained increase in ATCO2 can also be one of the earliest signs that the patient has achieved ROSC, meaning their heart has started beating effectively again.
So we've recalibrated the rhythm of saving a life with CPR and revolutionized the approach to breathing. But what about the miracle drugs we see in medical dramas? You might imagine an arsenal of medications flying into action, yet the real-world science of resuscitation has actually been pruning that pharmacy, revealing surprising truths about what truly works and what's surprisingly unhelpful in those critical moments. What's the one drug that seems to be universally indicated?
That would be epinephrine. It's really the only medication indicated in sudden cardiac arrest, regardless of the initial heart rhythm. Epinephrine acts like a potent constrictor on your blood vessels. By squeezing those vessels, it dramatically increases overall blood pressure. Why is this crucial? Because even if the heart isn't effectively pumping, this elevated pressure helps push essential blood flow to the heart muscle itself and, most importantly, to the brain, giving those vital organs a chance at survival.
And when is it typically given? Is there standard timing?
It's usually administered as 1 milligram intravenously, IV, or interosseously, IO. We can talk about IO in a sec, every 3 to 5 minutes. In patients with shockable rhythms, meaning rhythms that can be treated with an electrical shock, it's typically given after about 2 minutes of excellent CPR if the initial rescue shocks aren't successful.
Now here's a truly counterintuitive insight, or maybe nuance. While epinephrine is the only universally indicated drug, recent large trials involving over 8,000 patients revealed something surprising. It definitely helps restart the heart, giving us a higher rate of return of spontaneous circulation, ROSC. But critically, it hasn't consistently shown an improvement in long-term survival, specifically at 30 days with good neurological function. That's a profound distinction. Bringing someone back versus ensuring they have a good neurological outcome. It tells us the picture is far more complex than just getting a pulse.
Precisely. It highlights the challenges in resuscitation research. We're not just looking for a heartbeat, but a meaningful recovery. And to add another layer of complexity, premature administration of epinephrine, meaning giving it too early, say within 2 minutes of defibrillation, has actually been associated with decreased survival in some studies. So timing is absolutely critical. It's not just about if, but when.
Wow, that's a lot to unpack with just epinephrine. It truly highlights that in emergency medicine, the simplest answers aren't always the full story. So if epinephrine has these complex nuances, what about other medications we might expect to see, like antiarrhythmics? Are amiodarone and lidocaine still commonly used?
Yes, antiarrhythmic drugs like amiodarone and lidocaine still have a role, but for very specific situations. They're primarily used for refractory ventricular tachycardia, VT, or ventricular fibrillation, VF, those chaotic, life-threatening rhythms that persist after, say, a second unsuccessful defibrillation attempt. While studies show little overall survival benefit across all cardiac arrest patients, there's some potential benefit in cases of witness collapse where these drugs can be administered relatively quickly. Amiodarone is typically given as a 300 milligram IVIO bolus, followed by 150 milligram if needed. Lidocaine is 1 to 1.5 milligram IVIO bolus, then potentially more.
And just as important as knowing what to use is knowing what not to routinely use. What medications have sort of fallen out of favor, perhaps due to lack of evidence or even potential harm.
Yeah, there have been several important shifts here. Atropine is no longer recommended for asystole, where the heart has flatlined, or for pulseless electrical activity, PEA, where there's electrical activity but no effective pump. Vasopressin hasn't shown any superiority to epinephrine, so it's not routinely recommended either. And perhaps most surprisingly for some, calcium chloride generally offers no benefit. In fact, one randomized trial was even terminated early because there was a trend toward reduced return of spontaneous circulation. It's only indicated in very special circumstances, like confirmed high potassium or calcium channel blocker toxicity. Lastly, sodium bicarbonate also doesn't provide routine benefit, though it might be considered for, specific situations like pre-existing severe metabolic acidosis or certain overdoses.
Getting these critical medications into the patient quickly is key. You mentioned IV or IO. What's the deal with IO? Intraosseous.
Right. So both the intravenous, underosseous, IO routes are considered reasonable and pretty much equivalent for medication administration during ACLS. IO access involves injecting directly into the bone marrow, typically in the shin bone, tibia, or the upper arm bone, humerus. It's often much easier and safer to establish quickly in a cardiac arrest situation, especially when veins are collapsed and hard to find. It's a very reliable route.
Okay. Is there any debate over which is better, IV or IO, ultimately?
There is some nuance there. While IO access often has higher initial success rates for just getting a line in quickly, some meta-analyses have suggested maybe slightly lower rates of sustained return of spontaneous circulation for IO first strategies compared to IV first. But overall, long-term survival doesn't seem to differ significantly between the two. The truly critical takeaway, however, is that excellent CPR should never be interrupted to obtain vascular access. That's paramount. If IV or IO access is genuinely impossible, the endotracheal tube can be used as an absolute last resort, but drug concentrations delivered this way are less predictable. And the doses typically need to be 2 to 2.5 times the standard IV doses diluted in saline. But again, it's really a last-ditch effort.
Beyond the individual skills and specific interventions, the success of ACLS hinges on something often overlooked: effective teamwork. When you have multiple providers, potentially from different disciplines, how do you make sure everyone is working together seamlessly under such immense pressure? This isn't just about medical knowledge, it's about human factors, right?
You've hit on a crucial point. This is where crisis resource management, or CRM, comes in. It's a set of principles, many adapted from the aviation industry actually, designed to decrease disorganization and human error during resuscitation and vastly improve patient care. At its core, CRM ensures the collective knowledge and experience of the team is utilized effectively, even in chaotic environments.
And what are the key principles of CRM that make such a difference in that kind of setting?
Well, the foundation lies in clear leadership and structured closed-loop communication. One person assumes the role of team leader. They're responsible for the overall management, assigning tasks, coordinating communication, thinking ahead. Crucially, the team leader should try to avoid performing technical procedures themselves, as that pulls their focus from their primary leadership responsibilities. Communication follows a closed-loop system. The leader assigns a task to a specific team member, that member verbally acknowledges it, got it, and then confirms its completion. Epi given, leader, give 1 milligram of epi. Team member, 1 milligram epi acknowledged. Team member, 1 milligram epi given. It avoids errors.
That sounds like it empowers everyone to contribute, maybe overcoming traditional hierarchies that might exist.
Exactly. All team members are strongly encouraged to speak up with observations, concerns, or suggestions. If something looks wrong, say something. Overcoming any hierarchy or fear of speaking out is key. Also, asking extraneous personnel to leave helps reduce noise and ensures clear communication. The goal is a highly organized, efficient, and collaborative environment where everyone knows their role and the patient benefits from the entire team's expertise.
What happens if repeated shocks don't work for ventricular fibrillation, or if the initial rhythm isn't shockable? Are there other advanced strategies for what we call refractory VTVF?
Yeah, for shock refractory VTVF, where standard defibrillation fails repeatedly, there are a couple of advanced strategies to consider. One is vector change, which simply means changing the location of the defibrillation pads on the patient's chest. For example, moving from the standard anterior lateral position to an anterior posterior position. The idea is to ensure the electrical current fully captures the ventricles.
And then there's a much more intensive high-tech option for specific, often younger patients, right? ECMO.
Yes, extracorporeal CPR, or eCPR, is gaining significant interest for highly selected patients. This involves rapidly initiating veno-arterial extracorporeal membrane oxygenation, or VA ECMO, basically an external heart-lung machine, as an adjunct to conventional CPR. It takes over the function of the heart and lungs, providing significantly better blood flow and oxygen delivery than CPR alone can achieve. eCPR can act as a crucial bridge, buying time to identify and treat reversible causes, like a massive heart attack, and allowing the heart to potentially recover. However, it's a highly complex and resource-intensive intervention, needing a lot of coordination and expertise. It's most effective when started very early in patients with favorable arrest characteristics and a likely reversible cause.
These situations are incredibly difficult, and for medical teams, one of the most profound decisions is knowing when to stop.
Hmm.
How do clinicians approach the termination of resuscitative efforts, a decision laden with so much gravity?
It is indeed a profoundly difficult decision, and while high-quality evidence to guide it is still evolving, several factors are consistently considered. These include things like the duration of the resuscitative effort, often greater than 30 minutes without a sustained perfusing rhythm. Also, an unwitnessed collapse with an initial rhythm of asystole, a prolonged time before CPR was even started, and of course patient factors like advanced age or severe pre-existing medical conditions that make survival highly unlikely, even if ROSC is achieved.
Are there any objective measures that help guide that decision, something concrete in the midst of all that uncertainty?
Yes, one of the better objective predictors we have is the ITCO2 level after about 20 minutes of resuscitation. A value consistently below 10 mmHg is a strong predictor of acute mortality, though it's absolutely critical to first rule out a misplaced endotracheal tube causing a low reading. For out-of-hospital cardiac arrest, there are also some pretty simple pre-hospital termination criteria that are often used. If the arrest was not witnessed by EMS, the initial rhythm was non-shockable, like asystole or PEA, and there's no ROSC before the third dose of epinephrine, the chances of survival are, unfortunately, virtually non-existent.
And what about the role of ultrasound in these situations? Can it provide definitive answers about stopping?
Point-of-care ultrasound can be very useful for identifying reversible causes of cardiac arrest, things like fluid around the heart cardiac tamponade or a collapsed lung tension pneumothorax. And it can help identify if the heart has actually started beating again, even if there's no pulse yet. However, it's crucial to emphasize that ultrasound should not be used as the sole basis for predicting outcomes or for terminating resuscitative efforts. It's an adjunct, a useful piece of the puzzle, but not a definitive tool for those ultimate, complex decisions.
This deep dive into advanced cardiac life support has really highlighted the dynamic, almost relentless nature of emergency medicine. We've talked about the absolute centrality of excellent CPR, how airway management has evolved from quantity to quality, the precise evidence-based role of medications, and even what not to use, Senkos, and finally, the immense power of effective team dynamics in these critical moments.
Yeah, if we connect this to the bigger picture, it's clear that ACLS isn't just a rigid set of instructions. It's a dynamic, evidence-based science constantly striving to optimize every single aspect of care. It's a continuous learning process driven by research, refining every detail from how we compress the chest to how we communicate as a team, all to give patients the very best chance at not just surviving, but achieving a, neurologically intact survival. That's the real goal.
Considering the continuous evolution of these life-saving guidelines, what stands out to you about the balance between rapid, decisive intervention and meticulous, evidence-based care? And how might understanding these shifts change your perspective on urgent medical situations in the future?